Welcome everyone for our Ethics Café. We will be talking about medical assistance in dying and mental health today, and very excited to have all of you here joining us. Let us begin with a land acknowledgement, and let us take a moment to ground ourselves in gratitude. So please use the chat to join me in a land acknowledgement. But before we even begin, just take a moment to reflect on the land where you are joining us from and to connect with gratitude to that location. Perhaps it is a place where you feel especially connected to the land. Perhaps you have a window and you can look outside, but just take a moment to connect with the land, to connect with where you are joining us from. And at the bottom right of this screen, you will see placenames.mapdev.ca. Please use the correct Indigenous name to acknowledge where you are joining us from. I would like to begin by acknowledging that I am speaking from Unama'ki, which is located on the ancestral and unceded territory of the Mi'kmaq, whose inherent rights were recognized in the peace and friendship treaties that were signed with the Mi'kmaq, Maliseet, and Passamaquoddy peoples from 1725 to 1779. This series of treaties did not surrender Indigenous land, resources, or sovereignty to the British Empire, but instead established rules for an ongoing relationship between nations. The treaties were later reaffirmed by Canada in Section 35 of the Constitution Act in 1982, and they remain active to this day. Let us take this time to pause in reflection and gratitude for the land where we live and work. We are all treaty people. So how does this impact what we do and how we do it? And how will it guide our work together today? This reflection is part of our commitment to fulfilling the 94 calls to action that were listed in the Truth and Reconciliation Commission's report, in particular those that relate to the profession of social work that we take this moment to affirm today. And the Nova Scotia College of Social Workers commits to translating this acknowledgement into action by seeking to implement the recommendations of the Truth and Reconciliation Commission's calls to action. We commit to doing what we can to becoming better treaty partners. We commit to learning and to unlearning. And we commit to using our professional development to both learn new ways of thinking and understanding the work we do, and to unlearn assumptions and bias so we can ensure safer social work practice and a more just world for all people. And we're grateful for the new Code of Ethics of Social Work that requires us to shift from the illusion of neutrality to becoming actively anti-racist and fighting against racism and all intersectional prejudice that is part of colonization. We recognize that becoming anti-racist is a journey from denying that it exists to being afraid to talk about it, to learning about it, to eventually growing and working on the ways in which unconscious bias is manifest in our work. We also recognize that safer social work practice means reflecting upon the ways that our positionality impacts what we do and how we experience the world around us. So we take this moment to reflect upon where we are and our own intersecting identities and our own self-awareness and how this informs our work and our learning. Decolonizing ourselves in our practice means recognizing the ways in which we are each impacted by the colonial system in which we all participate, and from which those of us of settler descent continue to benefit. Each of us, depending on our social location and intersectional positionality, are uniquely oppressed or impacted. For example, those of us from African descent were dispossessed and uprooted from their land and brought to Turtle Island against their will as part of the white supremacy and slave trade that fueled the settlement of this continent. So we reflect right now upon the unique impact of colonization on each of us and our practice. And when we acknowledge the land, we also begin to acknowledge the wisdom of this planet and align ourselves with its truths. So let us take this moment to pause in gratitude for all who have and continue to heroically care and advocate for this beautiful land, and may we join them in this sacred work. Let us ground ourselves in the wisdom of the land-based Mi'kmaq teachings and values that we must all begin to learn. And let us work to decolonize ourselves, our practice in this community that we share, by working for justice for all living beings, and as an expression of our gratitude for being here. And let us take some deep breaths now as we prepare to learn. And let us recenter ourselves away from the violent ways colonization fills our world and fills us, that we can let go of the unconscious bias that is everywhere, inside and out. And may our session today lead us to be in right relationship with this land and with one another. We hope to be also offering at the very end, if you are joining us live, not if you're joining us on YouTube later, we will be giving away some books, some conference tickets at all of our Social Work Month events, because March is social work. So please stay till the very end in order to win a prize. But with that, we are beginning our session now, and I am very excited to have an amazing group of people who are joining us, including Dr. Marika Warren, who is with the Nova Scotia Health Ethics Network, as well as the system ethicist for Fraser Health. Moji is going to be joining us. We will be beginning with Professor Archibald Kaiser from the Schulich School of Law at Dalhousie. And we will also have an opportunity to hear from Karn, who is Executive Director for the Canadian Mental Health Association, Nova Scotia chapter. And of course, our social workers, we're going to have a chance to hear from some of them, as well as we are so grateful to have a first voice speaker who we will hear from in a few moments. But without further ado, I'm going to introduce Professor Kaiser. Thank you so much for being here. And I am going to share Professor Kaiser's screen. And here we are. Over to you, Professor Kaiser. Thank you so much for sharing your knowledge and wisdom with us to help us understand this concept of the expansion of medical assistance in dying, so that we can begin with a legal concept. Then we will ground ourselves with some first voice experience of how this actually impacts the people that social workers might be working with. And then we will be talking about ethical issues and ways that we can work together to ensure safer social work practice for all. So over to you, Professor Kaiser.
Well, good afternoon, everyone. Thanks so much for taking an interest in this vital topic. I've been assigned an impossible chore, which is to explain the law surrounding medical assistance in dying and its development in 10 minutes. So I'm going to be hurried, but I hope it won't be too rushed for you. You can feel free to contact me if you'd like to have copies of my slides, and there are 35 of them. I'm not going to go through those after our seminar. Okay, so next slide. So this is what I'd like to cover. First of all, and lawyers are always concerned with defining things. So what is medical assistance in dying? Then I'd like to trace how the law has developed through the court cases in Parliament. Then I'd like to look at the current law. And then to some extent, I'd look at the controversy surrounding medical assistance in dying from a disability rights point of view. I will present the law from a mainly neutral perspective. I also want to be honest with you. I've been a vocal public opponent of the extension of medical assistance in dying, so-called, to persons with disabilities, and even more to more recently the consideration of it being provided for persons whose sole underlying condition is mental illness. So I make no bones about my own opinions. I've written editorials, I've appeared before Parliament, and so on. So in that sense, I'm not neutral, but the early part of this, at least, will be rather blander in that sense. So next slide. So, let's understand what we're talking about. Medical assistance in dying, then, as you can see here, is a process that allows someone who's been found eligible to be able to receive assistance from a medical practitioner in ending their life intentionally, right? So, this is a criminal justice issue. There are many other, actors who are now taking interest in it, but I want you to appreciate that we're talking about having a justification for performing something which would otherwise be a crime. There are two methods of medical assistance in dying. One where a health practitioner directly administers a substance that causes death, and another that prescribes or provides the drugs where the person, it brings about the end of their own life. Next slide, please. So, it's only 1992 when the Rodriguez case in the Supreme Court of Canada dealt with the issue of whether it should continue to be a crime to assist somebody in committing suicide or to cause somebody's death, notwithstanding the fact that they've consented. That is still the law in Canada. Let's make it clear. And there's another crime called administering a noxious substance. So we're talking about things which are crimes unless, and we're going to look at the unless. So in 1993, in the Rodriguez case, the Supreme Court of Canada said that this is still a crime, and they would admit of no exceptions. At that time, as well as on many other occasions, the court heard about the need to protect vulnerable people. Next slide, please. It was the Carter case in 2015 where, as I said here, the Supreme Court did a complete turnabout as a result of their reconsidering some essential constitutional doctrines. They said that their previous stance was wrong, and they wanted to recognize the freedom to choose for competent adults, knowing that they had to balance it, against the importance of life and the need to protect vulnerable people. It should be, acknowledged that at the time of the Carter case, people with disabilities, voiced their opinions as being opposed to making this lawful. Next slide, please. So the Carter case from the Supreme Court said the following, that the ban on assisted dying was no longer good law insofar as it completely prohibited it. The court decided to reject the bans on assisted suicide, where the adult clearly consented to having his or her life ended, and the adult had a very serious and incurable medical condition that caused the person to suffer so much they couldn't tolerate it. Next slide. Federal government introduced legislation to respond to the Carter case in Bill C-14 in 2016, which provided that the criminal code, we're talking about the criminal code again, could be amended and would be amended to permit medical assistance in dying if the person was more than 18, had a serious and untreatable medical condition, and they were declining and could not be helped, they were suffering and they couldn't bear it, and in the original version of the law where their natural death was reasonably foreseeable. Next slide. The Truchon case from the Ontario Superior Court weakened this protection in 2019. It was only a single judge, who made the decision. That judge said that requiring that people had to demonstrate reasonable foreseeability of death was unacceptable under our Constitution. Unpredictably and without obvious precedent, the government of Canada decided not to appeal and just brought in new legislation. So they, in my opinion, rushed into introducing Bill C-7 in 2021 after the Truchon case. The major changes were that the criminal code was amended to say that your natural death no longer had to be likely, and they introduced two tracks, for persons to receive medical assistance in order to die, not medical assistance in dying. Track 1 then would be for people whose death is reasonably foreseeable, and track 2 for people whose death was not reasonably foreseeable, and this could include people with disabilities who are not dying. There was an important exclusion then saying that for persons whose sole underlying condition was a mental illness, they wouldn't be eligible until March 17, 2023. That was later extended to 2024, and it's been extended again to 2027. Next slide, please. So the law as of 2021 said that MAiD, medical assistance in dying, would be permitted, not be permitted for conditions which are in the domain of psychiatry, but on the other hand, could be provided for persons with neurocognitive and neurodevelopmental disorders or other conditions that could affect their cognitive disabilities. It was, as I mentioned, in 2024 that Bill C-62 was introduced that said for people with mental illness only, the exclusion continued for them until 2027. And the Minister of Justice said we must ensure our healthcare system is prepared to fully protect and support those who are vulnerable, an ongoing concern in this regard. Next slide. So the current eligibility criteria for these two tracks are that, shared criteria. You must be eligible for health services. You must be at least 18 and capable of making your own decisions. You must have a grievous and irremediable medical condition. You must make a voluntary request, and you must give informed consent. Let's go next slide. A grievous and irremediable medical condition is one, where all of these criteria must be met. You must have a serious illness, disease, or disability. You must be declining. You must experience unbearable physical or mental suffering from any one of these conditions that cannot be relieved. Next. You do not need to have a fatal or terminal condition as of the current state of the law. And if your only medical condition is a mental illness, you are not yet eligible, and you may not become eligible for medical assistance in dying. If you do have a mental illness along with other medical conditions, you might be eligible. Next slide. For track one, where your death is reasonably foreseeable, you must make a request in writing with the witness. Two health practitioners must provide an assessment and confirm your eligibility. You must be informed that you can withdraw your request at any time. You must be given an opportunity to withdraw before you receive MAiD, and the person can waive the final consent where they're at risk of losing their decision-making capacity. Next slide. Track two is for people whose death is not reasonably foreseeable, and this is what has been extremely controversial. Again, there must be a written request. Two healthcare professionals must certify that you meet the eligibility requirements. You must be informed as well. You can withdraw, and you must be informed of available and appropriate means to relieve suffering, including counseling services, mental health and disability support services, community services, and palliative care. The law does not say that you must have had those, just that you must be informed about their availability. And again, for people whose death is not reasonably foreseeable, there must be a discussion about ways to relieve your suffering. Normally, the eligibility assessments must take 90 days. You must have a chance to withdraw and still consent before you want to go through with it. Next slide. Obviously, this has been very controversial for disability rights organizations. I'll refer to only three, and then my time is up. People First of Canada, an organization for which I'm an advisor, has said, we are against the law that would allow ending a life just because a person has a disability. In short, People First has said, please vote to kill the bill, not us. The CMHA originally said that they're deeply disappointed that the government supports those who may have mental illness, to possibly receive MAiD, but they, at the time, specifically opposed it. Inclusion Canada, which advocates for people with intellectual disabilities, said that we must avoid sending a message that having a disability is an acceptable reason to be put to death. For disability rights organizations, these issues continue. And I'll tell you that's enough for my slides for the time being, because my time is up. But I'll tell you, it was only last Saturday that I provided a lecture for People First Nova Scotia. This is an organization of persons who have intellectual disabilities. They continue to be opposed, to the extension of MAiD for persons with disabilities, and specifically for persons with intellectual disabilities. And they continue to say, we want our lives to be supported. We don't want our deaths by suicide to be facilitated. So that's the end of my portion. I know that's an express tour, but that's the time I've been given. Thank you very much.
Thank you very much. I'm very grateful to you for sharing some of your wisdom. I put my email in there so people can contact me for copies of slides, as well as some of the other resources that people are going to be sharing. This is obviously an incredibly complex topic, and this is only one part. We've had a chance to hear from Professor Kaiser previously when we were introducing the guidelines for social work practice in medical assistance in dying. And we've also had a chance to hear from some of the participants on this panel when we had an ethics cafe more broadly. We will have a chance for questions at the very end. We want to give everyone a chance to speak first. And so I'm excited to introduce, some of you may already be familiar with Tristan, but Tristan is an autistic individual with a variety of physical disabilities, and has has a story about that they want to share. Tristan wrote this, and I am going to be reading it on his behalf. And so I'm going to read what he said, but he is here and can respond. All of our participants can respond via chat if you have any comments or questions. So we want to hear the lived experience and first voice perspective of somebody who was considering MAiD. And so I will just read it. Last year, I was looking into MAiD because services to live were not offered. I moved because of that, essentially feeling like the absence of assistance to live is letting people die without assistance, which isn't much better than offering MAiD. Definitely seems like a common issue with people choosing MAiD when adequate support to live is not an option. It's interesting that one of the major concerns about MAiD for mental illness is the lack of access to mental health care, as if the lack of access to every other form of care is adequate, and as if inadequate mental health support is irrelevant to people accessing MAiD for physical conditions. I was watching a documentary about a Halifax doctor named Shelley Sarwell getting medical assistance and dying for terminal illness, and her reasons for choosing MAiD over other end-of-life care options were largely because those options weren't acceptable for her. It totally makes sense not to go through the emotional process of learning to be okay with getting help in distress over declining function, when that might take longer to get comfortable with than time person has left to live. Her story was the first time I really realized that even with terminal physical conditions, it's psychological and relational factors that lead to decisions. I was surprised at how many of the reasons I would have wanted MAiD were the same. It made me wonder how many people who could adapt to living differently and have a good quality of life end up getting MAiD because it takes a longer time to get reasonably okay with accepting help, and it doesn't seem like it'll get better until it does. It's interesting that MAiD for mental illness is such a concerning idea when potentially less permanent mental struggles like this are an allowable reason for MAiD, especially for people who do have time to adjust. It's also disturbing to consider many common, not necessarily terminal conditions that inadequate healthcare to prevent complications can create an irreversible state of decline. I suppose that doesn't really change anyone's current condition, but it does seem strange that MAiD for mental illness is being delayed due to concerns that systemic neglect, rather than some individual factor attributable to someone's condition, would be the reason people seek MAiD, while it's acceptable for people with other underlying conditions. It's a pretty urgent issue to address all the concerns being used to justify delays, because the reasons aren't exclusive to mental illness. For example, the fact that we're concerned about safeguards means that we should be monitoring whether the safeguards to MAiD are actually being followed and in ways that offer similar levels of service to relieve suffering across Canada. Personally, I'm less concerned about including mental illness as a sole underlying condition, and more concerned that some of the people seeking MAiD without reasonably foreseeable deaths are being forced into it because there are no other options available. The current safeguard just says you must be informed of available means to relieve your suffering and offered consultations with professionals who provide services, including, where appropriate, palliative care, community services, counseling, mental health, and disability support services. The safeguard does not include consultations with professionals who can provide treatments or management options for specific issues causing suffering. It does not say how quickly the professionals need to see you. It provides providers wiggle room to say, in this case, we don't think these services are appropriate, so you don't need to offer. And if we are so concerned about mental health service availability and discussions around MAiD for mental illness, then do we really believe that they're available to everyone who needs support with other conditions? Or how accurately could professionals assess whether someone's mental suffering is a result of the eligible condition or a mental health issue that's treatable? On paper, Nova Scotia has the same services available as I got in Alberta. And I think it's worth noting for those of you who are listening that you may recall Tristan spoke at our Ethics Café this summer in August, that Tristan tried to get services in Nova Scotia, was not able to, was thinking about MAiD, but ultimately moved to Alberta in order to get the services that he could not get here in Nova Scotia, which is why he's sharing his perspective from a first voice perspective. So this is what Tristan has said. On paper, Nova Scotia has the same services available as I got in Alberta. The difference is I was in Nova Scotia asking for help with those basic needs, and it never happened for me. They would mention options, but never provide them. One of the major differences is in Nova Scotia, I could wait hours for first responders to come and help if I fell or got stuck. But in Alberta, at least in city and surrounding areas, it's always been 15, maybe 30 minutes, and sometimes so fast, I wonder if they teleported here. Also in Alberta, I got options that improve, Also in Alberta, I got options that improve mobility and prevented health issues, so I don't need emergency services. The thing that makes the biggest difference to me is knowing if I need emergency services, they are available. And that's something that MAiD safeguards are not changing. A MAiD program competent in mental health would consider mental and social barriers to the services being offered to relieve suffering and to accept treatment or management options. In many ways, MAiD for mental illness is made for every illness. If MAiD program is not safe for mental illness, then it's not safe for anyone because mental health is intertwined with conditions that are currently eligible for MAiD. In my experience, mental health professionals are even less equipped to understand, much less support people with mental health issues related to non-mental illness conditions. So if they're concerned about not understanding mental illness enough to assess MAiD, then why do we believe medical professionals understand mental health issues when we add ableism to the mix? One concerning example of this is autism, being an eligible condition for MAiD in a world with inadequate understanding and mental health support for autistic people. While I'm glad to see government recognize that being autistic is not a mental illness, it's a bit strange that nobody was concerned about the lack of knowledge professionals have about autistic people and how to improve quality of life, or the lack of services available to autistic adults, or the fact that many available services cause autistic people suffering. Maybe the issue with MAiD for non-terminal conditions is that doctors are not the right people to be assessing disability. And being a specialist on a condition does not make doctors understand the circumstances that would lead to seeking MAiD. Specialists in a condition are not always familiar with psychosocial and societal factors that are very relevant to suffering. It's disturbing to me that Canada's MAiD criteria says suffering can't be relieved under conditions you find acceptable, which sounds like individual choice, but it's not, because does anyone find it acceptable to wait months or years or not even having certain services available and knowing the horrible ways you could die because the services are not available? It would be nice to see MAiD safeguards, including providing the services needed in more creative ways if needed, such as out-of-province care, or helping someone move to a province where there are acceptable conditions to relieve the person's suffering. The Canadian government also says MAiD requests cannot be the result of outside pressure or influence. While I get that this is likely referring to no direct influence, such as cases where people were offered MAiD when they were just seeking support, ableism and inadequate healthcare and social services are a form of pressure, constantly pressuring disabled people to die. Not usually in such direct terms, but needing to fight to live means dying is the default, and arguing why I don't want to get any closer to that default and hearing descriptions of someone closer tell me that services will not be available, which is pretty strong pressure to have MAiD as a last resort. Thankfully, I decided to try a new province instead of waiting around with that in the back of my mind. But that is not an option offered as a safeguard for people seeking MAiD. And moving on your own is risky, especially with unstable or unmanaged health issues. That said, I have gotten services here and gotten letters months later from Nova Scotia with an appointment for that service. It's a pretty wild comparison. especially considering how much that one thing improved my life and has stopped me from needing emergency services. MAiD for people who are not dying for medical reasons, but are dying for social ones, is a disturbing situation. And it's really a chicken or egg thing, with some saying non-terminal conditions shouldn't be eligible for MAiD without adequate support available for disabled people to live. But on the other hand, dying in the ways that level of neglect allows isn't a clearly morally better situation. The letting disabled people die approach is easier to deny, whereas MAiD is somewhat more visible, although ableism is somehow so strong, it's upheld the denial of responsibility for disabled deaths, even when it's so clear. We maintain a society where disabled people were not meant to live, instead of building one where disabled people can live, meaning at bare minimum, disabled people no longer need to be concerned about threats to health and survival from external factors such as inadequate housing, healthcare, medical supplies, mobility aids, food, and other basic services. I think MAiD could have a place in non-terminal cases, but it needs to be much more specific and safeguard against making decisions that most people in a similar situation would not make later on. I'm thinking, like acquired disabilities and complications of pre-existing conditions, 90 days is not long enough for people to process what happened and adapt or find new ways of enjoying life. The government gave an example that people with spinal cord injuries and depression are eligible, which I'm really hoping experts in spinal cord injury are flagging, that depression is common after injuries and giving people a chance to adjust before considering MAiD. It seems like mental health issues can be a primary motivator for MAiD, but because a person also has a physical condition, that doesn't matter. I was going to say, I wonder why that happens, but the answer is ableism, the view that physical conditions are valid and understandable reasons a person wouldn't want to live, and the assumption that life couldn't possibly get better without the underlying condition improving. Okay. And then Tristan has shared some information and has offered to share some of that as well. I put my email if you want copies of Tristan's comments. Tristan, again, has autism as well as a variety of physical disabilities that led to their needing to move out of Nova Scotia in order to access support. So that is, I'm very grateful to Tristan for sharing some of his story with us so that we have a chance to hear from first voice perspectives. Obviously, this is a really complicated issue. There are legal concerns, there's first voice concerns, there's also people close to first voice. So I'm going to ask now Lisa to please, where's Lisa? Oh, there you are, Lisa, sorry. I'm going to introduce Lisa, who is a social worker who's going to share a little bit. Our goal is to hear as many different voices as possible all together so that we can begin to think about what does ethical social work look like in the many complicated, nuanced cases that we might encounter. Lisa, thank you so much for coming and sharing a little bit about your perspective as a social worker.
All right, so thank you for having me. I'll start with MAiD for mental health wasn't something I anticipated would come into my work life because I work with youth population. So I don't typically see people who would fall under the age that's been mandated. As a social worker, I work to support a lot of those kind of baseline social determinant of health supports that are necessary for people to actively engage and benefit from evidence-based care. And through the course of my work, I met a youth this fall who shared that their parent had been considering MAiD for mental health and only for mental health purposes. And through the course of working with this youth, I've learned that this parent has been a regular recipient of services, both inpatient and outpatient services, and the mental health concerns consistently are present. But before that, there's chronic and ongoing issues with poverty, There's chronic and ongoing issues with housing security. And it's very difficult for people to actively engage and participate in mental health services in a way that creates change when they live in a chronic state of perpetual crisis because they lack adequate supports for their basic needs of life. So we really need to advocate that we have better supports for our community so that people have adequate and safe housing, that they have adequate food, that their basic needs are met so that they are more able to engage and benefit from mental health services. And then we may not see people looking for MAiD as an out because they have benefited and improved their quality of life. And I know that's pretty brief. I'm also aware of the timeline, so I think I will wrap it up at that point. And if there's any questions, I'll respond to them after. Thank you.
Thank you so very much for sharing some of your perspective as a social worker working in this situation and helping us begin to think about some of the lived experiences that we have. So we got to hear from the legal perspective. We got to hear from somebody who was considering MAiD and who had to move out of province to begin to get medical assistance in living. And then what does this look like for social workers who might be working with family members who are dealing with these very difficult decisions? Now, of course, healthcare providers are in very difficult situations, and there are many other complicated ethical issues, and that's why we're so grateful to have two health system ethicists. The first is, you may remember her, but she spoke at our annual conference, and she is probably one of the most brilliant teachers I've ever heard. So grateful to have her brilliance with us. Moji, over to you. Thank you so much.
Thank you very much, Nash, and thank you all for having me on the panel this morning. In Fraser Health, which is my health authority in British Columbia, as with other areas in the province and in the country, there are ethical discussions and concerns about how social, economic, or psychosocial vulnerabilities may contribute to requests for MAiD when mental disorder is the sole underlying medical condition. It's been argued that because of the complexity the situation presents, it's hard sometimes to design which factors are involved. Oversight of MAiD in British Columbia is provided by the MAiD Oversight Unit within the Ministry of Health. Each health authority in the province then sets a committee that develops the process for operationalizing MAiD according to clinical and legal standards. My health authority has a MAiD steering committee whose mandate is to provide leadership and oversight to the implementation of medical assistance in dying for our region. The ethical concerns, among others that have been identified, include, and I'm going to be very brief here, but I'm highlighting the top ones. First, complexity with respect to assessment criteria and practice for patients with mental disorder as the sole underlying medical condition. Also, how to ensure informed consent, voluntariness, and patient autonomy are respected when contextual factors such as inadequate access to housing, mental health support, and community resources are exacerbating suffering or impacting a patient's quality of life. And the third one, which relates to the clinicians, is how to balance the rights of patients to access MAiD and the rights of clinicians to honor their conscience and to maintain professional boundaries that support their own well-being. Responding to the ethical issues that emerge in the consideration of having MAiD available for individuals with sole mental health diagnosis is ongoing work. Fraser Health, my health authority, collaborates with those impacted to ensure the integration of ethical considerations when responding to requests as the practice of MAiD continues to evolve. An ethicist is a member of the MAiD steering committee. ongoing work that is being done and revised with evolving direction in the provision of MAiD include development of a value-based decision-making framework through which a set of values were determined to be used as part of the decision-making process. The steering committee recommends the use of the framework, especially in any decision that may be controversial or where partnership of multiple stakeholders is crucial for effective implementation. I will mention 3 specific commitments, among others, that the framework recommends that any decision about providing MAiD lives up to. The first is respect for patients. We ask, does the proposed recommendation for a particular patient ensures that patients are not coerced into having MAiD, that patients are supported to think through their goals of care? And we explicitly outline that the rationale for this approach is that MAiD represents a change in practice, and the outcome of MAiD is irreversible and permanent. At the best of times, patients may not have clearly formed beliefs and values about their goals of care and how various treatment modalities fit into their lives. The framework emphasizing that clinicians provide support and a clear decision process that enables patients to make informed decisions as much as possible. The second commitment is commitment to patient well-being. We ask, does the proposed recommendation for a particular patient ensures that patients have access to excellent health care, including end-of-life care and mental health support? Do patients feel supported to ask about other options specific to their health care and supported to pursue those? We explicitly outline that the rationale for this approach is that in the changing law and society, the society has agreed that it is a reasonable choice for patients to choose death over life of certain quality. However, patients should never choose death because they are not receiving reasonable and possible quality end-of-life care, including the management of pain and suffering, however the patient describes or defines that for themselves. Our third commitment, among others, but these are the 3 that I really want to flag, is commitment to equity and social justice. And this value is crucial for us because in our health authority, we serve a very diverse patient population, and so we place a high importance on equity. The framework provides a great understanding of the importance of equity and the risk of living up to it in our society. So, in a nutshell, those are the top ethical concerns that have been identified, that we identify and we walk through, and also the related ongoing work. Thank you.
Thank you so very much. This is a very complicated topic, and we've been at a very kind of like high level structural. We've also got some lived experiences. Many of us have our own personal experiences. I know, for example, someone close to me chose to end their life with MAiD this summer, and it was a beautiful experience for that person and their family because of the complicated situation they had in terms of cancer, and that these are very complicated decisions. And the larger context of the kind of healthcare that we want to see is something that we are continuing to advocate for. And many of our members are doing this work, and both in terms of like expanding palliative care and hospice across the province, in terms of advocating for structural justice issues, but then specifically medical assistance in dying. And in fact, our guidelines were developed by social workers who were working with Nova Scotia Health Authority on that. And it's so great that we have so many different people from across the country joining us. But Annette, God bless you. You are with us doing important work. Tell us a little bit about what you think that social workers at Nova Scotia College of Social Work need to know and understand around this really complicated topic.
Absolutely. Good afternoon, everybody, and thank you for inviting me. Happy Social Work Month I'm Annette, and I've been on the MAiD team for about a year. This fall, I was joined by a second social worker, Katie Sims. And I think that's actually the first thing that the MAiD team has done, is actually acquire social workers for the team. Many provinces don't have social workers on their MAiD teams. And almost as soon as I started, I was asked to join a working group. And I'm going to talk to you a little bit about what the working group considered. I know we don't have a lot of time, but I'm just going to say that that working group immediately asked me to join because they realized, not just because of NSCSW, but also the track 2 patients that they were seeing who also had mental health concerns. That's not why they were seeking MAiD, but there's, they wanted to know, how do we tease out all of this? How do we tease out the vulnerabilities that we see in the people who are requesting MAiD? Our requesters are, chronically, ill-housed or unwell, have little access to certain resources. So that is generally how people were feeling about some of our track 2 patients. I just wanted to let you know who was on our working group, not specifically who, but we had the working group consisted of a few psychiatrists, some folks who work in mental health and addictions. Of course, some of our MAiD team members were on that team, and health ethics. Marika is on that working group. And also members from the Department of Health and Wellness. The reason it was kind of convened, the working group, was because they were seeing vulnerabilities already in track 2 patients, and really concerned that some people would be forced to consider MAiD when really there were unequal access to resources, or they just were unable to access the kind of help that they should be receiving. One of the first things the working group looked at was the Camberwell Assessment of Need. And I don't know if anyone is familiar with that, but I think it's often used by mental health professionals to assess vulnerabilities in a population. So part of the working group, one of their duties was to create an assessment that involved looking at vulnerabilities through the Camberwell Assessment of Need. And I think I gave Naj a kind of a link to online resources and the actual Camberwell Assessment of Need, which is free to most people online. So you can take a look at that. There are safeguards that they wanted to ensure were in place regarding MDS-UMC, as well as all of our other track 2 patients or requesters. And so one of those things would be like, is this person making an informed decision? Is this, how do I tease out the suicidality of this question versus a reasoned wish to die? So myself as a social worker and other folks on the team came up with a very long document in order to assess folks, and kind of cut it down to about 10 pages, recognizing that that would be, difficult for folks to get through. One of the assessors would need to be a psychiatrist or someone with expertise in the illness that the person has. So that is one thing that the team decided would need to be considered for eligibility. The working group especially worked on pathways. So pathways to care for people deemed eligible, but also pathways for people deemed ineligible, because the immediate feeling is that many people, if we look at folks in Belgium and in the Netherlands and in Switzerland, the majority of people who request are denied eligibility. And so in essence, you're telling people, you know what, you're not suffering enough. And that is, you know, already the client's perception and folks' perception. Client's perception and folks' perception of the assessing folks' perception are kind of clashing already around suffering. So yes, there's also that. So getting back to pathways of care, the team started working with pathways for mental health care and how people who are deemed ineligible, where would we have them go in terms of accessing support and accessing help. One of the things I did was I included, one thing I sent to you, Naj, was Bridge C14 website. And the Bridge C14 website is fantastic in that it has groups, support groups, peer support groups, and general support groups for folks seeking MAiD or thinking about MAiD. And there are some specific groups for folks who would qualify under Track 2 or MD-SUMC, which medical disorder as sole underlying medical condition. So, you know, there are certain pathways that the team have kind of come up with in order to support folks a bit better. In fact, for some of our Track 2 patients who also have mental illness concerns, our Track 2 patients who are suffering due to pain, we all know the pain clinic is like a 2-year wait list to get onto the pain clinic. And so our team kind of negotiated with the pain clinic in order to get folks assessed a little bit more quickly, maybe not become clients of the pain clinic, but assessed. The other thing too that our team is doing on a higher level than myself is trying to make inroads with different groups that are traditionally not served well by Nova Scotia Health or served inequitably by Nova Scotia Health. So, so there's pathways, we're working on pathways. We worked on pathways of care for mental health folks and worked on pathways of care for people who are experiencing specific difficulties with pain in that way. And then we've also been in contact with the Dal clinics and other community clinics and community services to help folks who have had difficulties in accessing resources in the community. Now, it behooves us now that we have 3 years, we have until 2027. It behooves us to say to folks, okay, so we've got 3 years now, we have 3 full years of lobbying government to get full access of resources for folks. And we need to do that. I mean, part of the reason why there are 2 social workers on the team is because we lobbied government, but now we have to lobby government for folks, for our clients, and for people in the community, for rural communities who don't have equal access to the stuff that we have here in the city. So this is ongoing, and we feel a little bit like we have room to breathe now because we have a little time we have 3 years, so we better get busy and start getting more money, more resources, that kind of thing, in order to kind of shore up our resources for our clients who are seeking MAiD, who are maybe not wanting to die, but seeing it as their only recourse. So having said all of that, I just, one thing I didn't do, Naj, is share my email. Certainly anybody who has any questions about what we're doing here on the MAiD team, any questions about how they can support people who they know, because we know that almost every social worker in Nova Scotia is going to be speaking with someone who has considered MAiD or who's thinking about it. So certainly feel welcome to email myself or the MAiD team as a whole. Be happy to answer any questions. We've certainly presented to lots of folks and groups and would be happy to do so in the future. Yeah, so I just wanted to do that before I finish my little spiel. Thank you so much for inviting me, Naj.
Thank you so very much. This is very complicated, and there's so many intersectional systems that really have to be looked at when we think about access to services, the larger ableism, the lack of access to universal mental health care, the racism. There's so many different areas, and yet how do we deal with the person in front of us is the question. So please put your questions in the Q&A. We have 2 more speakers to go. And Dr. Marika Warren is here, and she, hopefully you all know her because she is part of our Ethics Café, and whenever we have ethical concerns, a lot of times they're not related to our social work ethics, they're related to ethical concerns about patient care, and Marika is working with the Health Ethics Network across Nova Scotia, and is doing something similar to what Moji is doing, but locally here, and so grateful for your being here with us to think through these complicated topics.
Perfect. Thank you so much, Naj, for the invitation. I always enjoy chatting with social workers as a collective in terms of just the level of sort of thoughtfulness and engagement with these sorts of questions. So I appreciate the opportunity. I should note that, as mentioned, I'm representing the Nova Scotia Health Ethics Network today, which means that sort of what I have to say is focused on the work that we're doing as a network around support. It might be different from arguments or substantive arguments that I might make about some of the ways that we're implementing MAiD here. So the role for NSCN really is oriented around support. And so that's both support for process related to MAiD. So as Annette mentioned, I've sat on the MAiD MD Sumac working group since it sort of got up off the ground. And really the role there is to take those deep values commitments, particularly that show up around our concerns related to capacity, irremediability, vulnerability, and suicidality, and really make sure that those values are being translated consistently into practices for everyone. As with any type of healthcare, ethics support is available for those challenging cases where patients or loved ones or teams or providers are really struggling with a particular set of circumstances. But unlike in some other jurisdictions, ethics isn't necessarily involved in every single MAiD case, that we really see the role in terms of sort of setting up that process and again ensuring that our values are reflected in practice, and then developing other sort of tools and supports. And I certainly look forward to seeing the framework that Moji and the team at Fraser Health are developing, because I think those are the sorts of resources that it's a really powerful way for ethics to be involved. We've also done support for teams where there are diverging perspectives regarding MAiD. And so again, really focusing on the values for providers involved and how to find a place where we can all feel that we're practicing with integrity. So that's another way that NSCN has provided support. And again, certainly around MAiD MD Sumac, but we've also been involved in doing that sort of way back to 2015, 2016, when MAiD was originally coming in, because as has come up in I think a number of folks' comments, a lot of the concerns that have been raised related to mental disorders as a sole underlying medical condition qualifying for MAiD actually apply to MAiD regardless of what the cause of folks' suffering is, especially for complex cases, but even for some of those sort of track 1 cases where death is reasonably foreseeable. Again, resource considerations, may play into timing in ways that we still want to be concerned about. So, for example, with the case of ALS, there was a patient in BC who, due to resource constraints, was choosing the timing earlier than otherwise because of the availability of support. So again, these concerns that we have are sort of live from the ethics perspective, regardless of the reason for the request for MAiD from a patient. And so, as Annette has mentioned, a lot of the work that was done because of the anticipation around MAiD MD Sumac coming through will still be integrated into practice for MAiD patients sort of regardless. And again, I think I would argue that it's going to provide better care for anyone who is seeking MAiD, again, whether they receive MAiD or not, for us to have that sort of attentiveness to all of those ways in which choices around MAiD may be being influenced by Black background conditions and existing inequities. And, you know, again, this has been flagged certainly in the chat and in a number of other comments. So again, echoing Annette's comments around, you know, the need for, you know, the advocacy and resources, you know, as one really important way of addressing some of the concerns that we have about the way that MAiD plays out in practice. And again, ensuring that sort of the deep values commitments that we have are reflected in our practice. So I'm happy to take questions at the end, but also recognize that I get to be a repeat presenter in this forum. So I will turn it over to other folks. Thank you so much.
Thank you so very much. And again, if you are joining us live, this is one of the things that we are so grateful for, is that we have the ability to have this partnership with the Nova Scotia Health Ethics Network, so that if you have questions or concerns about the patient in front of you, as opposed to the larger structural social justice advocacy issues, the patient in front of you, how do we relieve their suffering? What are the options in that particular situation? So grateful to know we've got like such amazing people that we can turn to, and that's been a big part of our work as well. This is also another familiar phrase. Karn Nichols, Executive Director for the Canadian Mental Health Association Nova Scotia chapter, our partner for our Advocacy Day that is March 25th, where we are advocating for mental health and putting first voice advocacy, our voices, to amplify first voices, people with lived experiences. So I'm grateful to have you talking a little bit about the Canadian Mental Health Association stance as it currently stands, recognizing that we are all in an evolving process.
Wow, thanks so much, Naj. And I really appreciate this opportunity because, you know, I'm certainly learning lots too. We each come in with our own lens on this specific situation. And it's been such a rich discussion, and I've learned so much. So as Naj said, my name is Karn Nichols, and I'm the Executive Director of the Canadian Mental Health Association, the Nova Scotia division. So what I find often out in community is that people know who we are, but they don't know who we are. So we're part of a federation that spans about 300 communities across the province. We employ about 7,000 people, but we're just one piece of that puzzle in Nova Scotia. We're essentially a collective of organizations that were bound by our mission and our vision, which I'll talk a little bit about in a minute. We've got the division and our 3 branches in Nova Scotia, and we provide sort of 3 pillars: advocacy, programming, and resources that help prevent mental health problems and illnesses, and they support recovery and resilience, enable Nova Scotians to kind of flourish and thrive. Everything that we've been talking about and dreaming of, I think. So here in Mi'kma'ki, we deliver safe and inclusive evidence-based programming and training and navigation support to Nova Scotians so that they can be well and they can stay well. These programs include a variety of things, including support finding and maintaining safe and affordable housing, assistance finding sustainable and well-paying jobs, a lot of things that are tied to our social determinants, access to mental health literacy tools and education. And these programs are free to access, and they're available to everyone living in Nova Scotia. So I'm just going to take about not even 5 minutes, I promise, to talk a little bit about the advocacy work that we do across the province and across the country. And often it's alongside the Nova Scotia College of Social Workers, which I'm so grateful for, because together we amplify the voice of those that need to be heard. So, you know, what I've noticed throughout this discussion today, I feel really privileged, as I said, to really understand all of those intersections, you know, between Professor Kaiser's insights about the legal complexities and Tristan's firsthand experience and Lisa's family perspective and Moji's and Annette's ethical considerations and Marika's insights into the Health Ethics Network. Each contribution really added a kind of a depth of the understanding that we have on the impact of MAiD. So I believe it, I feel in my heart that it's a contentious and intricate issue that kind of bumps up into our individual morals and values as well. And that's what keeps the conversation going. So at the heart of the dialogue lies not only just the ethical implications of MAiD, but also the broader question about how are we supporting the individuals grappling with mental health disorders in their families. And this has obviously been a theme that's threaded its way through all of our conversations. With the government postponing the MAiD until 2027, we're sort of at a crossroads, and we have to pause and reflect. And, you know, as we heard, we've got 3 years to really, you know, make a difference. And so we want to really contemplate the values that guide us and include the and think about the inclusive future that will create for every single human being within the province, irrespective of race, socioeconomic status, sexual orientation, or ability. It's a reality that we want to create and work towards together. So as far as our advocacy goes at CMHA, our mission is to ensure that every individual can access the comprehensive range of mental health and substance use health programs and supports guaranteed to them under international human rights law. Universal mental health care, as we envision it, involves the seamless integration of these essential services into our public healthcare system, available to all at no cost. And this encompasses not only the traditional ways of doing this, the treatments, but also life-saving interventions that are currently unavailable to everybody. Additionally, it also means that these services are culturally sensitive, trauma-informed, and grounded in principles of health equity. We believe that Canada and our province is failing to meet the human rights obligations when people with mental illness cannot receive these programs, supports, and resources that they need to be well and live with dignity. And that's where the conversation really gets, you know, very important. So said another way, our governments have an obligation to ensure that a person has all the resources that they need to live. An absence of affordable housing, income supports, and/or food security must not be the reason that someone chooses MAiD. And as Tristan said, dying for social reasons, right? So it's something that we really need to focus on as we have this 3-year window. Investing in mental health and substance use health isn't merely a matter of moral obligation. It's also a strategic imperative for our communities. And I think it's a really intelligent choice. It's not a matter of just fairness. It's a recognition of the interconnectedness of our well-being and the strength of the society as a whole. By prioritizing mental health and the substance use health, we invest in healthier individuals, stronger communities, and a more resilient province, nation, full stop. So at CMHA, we've got some sort of buckets when we look at advocacy. We advocate for a universal system that is real and fair and grounded in supporting wellness. So universal system would give all people, as I've said, in Canada, access to publicly funded mental health and substance use health services, no matter who they are or where they live. We know, because we practice, these services must be equally available for all, be portable when moving in between provinces and territories, and they must be provided free and without discrimination. Advocating for a real system means that we want to ensure that the front door to support is both obvious and accessible, and it leads to a clear path of health and well-being. When we did our strategic planning about 3 years ago, that was a really common theme when we went out into the community to ask about their experiences. And often people said, I don't even know where the front door is. I don't know how to get in. And then once I get in there, I don't know how to navigate my way through to wellness. And so this is really an important thing to keep in mind. So what that means is this means a shift away from a patchwork of hard to find and waitlisted mental health and substance use health services. And it also means more community-based organizations like ourselves and many others out there are no longer funded by short-term grants or donations alone. It just means that it also means that counseling and psychotherapy services will be accessible to all, not only to those who can pay for them. And it means creating a real system of integrated, accessible, publicly funded care backed by long-term sustainable core funding for community-based services. And this is a really important piece that sometimes doesn't get addressed, but it's actually the source of how we can start to make some of these systems work a little bit more fairly and equitably. We believe and advocate for a fair system. We all play a role in righting the structural inequalities that lie at the heart of poor mental health and substance use health concerns. That requires, as you all know, and I know you experience every day, the harms that are caused by colonialism, racism, sexism, and ableism that permeate the healthcare systems and lead to poor health outcomes. It means that taking an anti-racist and anti-oppressive approach to policymaking and service delivery. as well as taking into account the social determinants of health and recognizing the importance of upstream preventative care. In practical terms, disaggregated data must be collected so that we know who receives the care, who doesn't receive the care, and begin to understand why not. We need to bring more transparency to the development of health policies and budget. While we close the gaps in access and addressing systemic discrimination, diverse people with lived and living experience of mental illnesses and substance use health concerns need to be included in a meaningful way in our healthcare and justice system reforms, especially in discussions like the one we're having today. Finally, we believe and advocate for a wellness system. We need to strive to make people well so that they can live full and healthy lives, recover, thrive, and accomplish their goals and dreams while giving back to the community and society as a whole. This includes recognizing the importance of mental health promotion, mental illness prevention, education, recovery-oriented approaches, and the elimination of stigma. Mental wellness requires a balance between the mental, the physical, the spiritual, and the emotional parts of ourselves. It also includes providing coordinated services that are culturally safe. So in closing, I just want to say, Naj, I'm just so grateful for this opportunity to spend this time today. As I've heard today and I've reflected on this opportunity, I really believe that social workers are the invaluable connectors within the social fabric of our communities. They act as advocates for those who feel kind of marginalized or unheard, and they bring together individuals who may feel isolated, and they provide platforms like today to voice concerns and experiences. I believe that coming together at events like today serves to strengthen our communities, because I think the best vision for a shared future is one where everyone's voice and perspective is heard and valued. And I really thank you all for the privilege of your time today.
Thank you so very, very much. We are so grateful for our partnership with you, and hopefully everyone is inspired to join us in advocating for the Canadian Mental Health Association's Act Now for Mental Health advocacy platform and our own advocacy goals, which we will have a chance to hear on March 21st